Hello and good afternoon everyone, and welcome to another of Scottish Drugs Forum's COVID webinars. My name is Trish Tougher and I am the Bloodborne Virus Network Manager with NHS Lanarkshire. I'd like to thank SDF for the opportunity to be involved and the invitation to chair today's session. This really is the most extraordinary of times and the most significant disruption to health and community systems that many of us will have experienced. In today's webinar, we will be focusing on the coronavirus pandemic and the subsequent lockdown and how it's resulted in specific challenges for women who use drugs. So in this webinar, we will be discussing issues around gender-based violence, homeless women and the HIV outbreak in Glasgow, and supporting women to access sexual and reproductive health needs. We're most fortunate today to be joined by three wonderful speakers. Our first speaker will be Dr. Sue Brechin. Sue is a consultant in sexual and reproductive health in NHS Fife, who will discuss gender-based violence with us. And specifically, Sue will be speaking about supporting staff to identify women at risk of GBV during telephone interactions. Our second speaker is Jenny Jamieson. Jenny is the Women's Outreach Worker for the BBV charity Waverley Care, and is part of their HIV Street Support Service in Glasgow. Jenny will be discussing her work with homeless women and HIV in Glasgow. And our third and final speaker today is Katherine Bethell. Katherine is an advanced nurse practitioner at the Chalmers Sexual Health service in NHS Lothian, and Katherine will be discussing supporting women with access to sexual and reproductive health services. So the process for today is we will hear from each speaker in turn, and after our third and last presentation, we will then have a question and answer session. So attendees yourselves, you can submit questions throughout the webinar to the questions tab that appears in the control panel, which should be on the right side of your screen. We will also be joined today by Leslie Bowen. Most of you will know Leslie, I'm sure. Leslie is SDF's Training Officer for Harm Reduction, Sexual Health and Bloodborne Viruses. And Leslie will join us for the discussion session at the end of the presentations and will summarise the questions being asked by our webinar attendees. So without further ado, I would like to hand over to Sue for our first presentation. We'll just wait for Sue to appear, and there she does magically. Yeah. Fantastic. Sue, I'm just going to disappear for a moment and I'll hand over to you. Thank you very much.
That's great, thanks Trish. Well, thanks very much for the invite to speak to you this afternoon. As Trish said, I'm Sue Brechin. I'm a consultant in sexual and reproductive health in Fife and worked in Grampian previously. I have a particular interest in women's health and in particularly women living with disadvantages, including homelessness, substance dependency and so on. As we all know, lockdown in March, and suddenly many healthcare professionals in particular moved from face-to-face consultations to phone consultations. And you know, our staff are experienced, they're used to safeguarding women and their health, and used to identifying people at risk of gender-based violence when we're face-to-face. But I noticed that very experienced staff were really struggling with that in phone consultations. So I put together a guide for our own staff, and then it sort of snowballed from there. We've shared it across Scotland and actually throughout the UK. So I'm going to just take you quickly through the resources that I've developed for that. And these will all be available for you to use yourselves or within your own services after the webinar as well. So when we're talking about gender-based violence, we mean things like domestic abuse, rape and sexual assault, commercial and other exploitation. And we know that although it's mostly, although not exclusively, women who are exposed to gender-based violence, we estimate around 1 in 4 women will be affected at some point in their lives. And the majority of domestic abuse will occur within their own homes. So the COVID pandemic, with the stay-at-home messages, stay home, stay safe, was really not applicable for many of these women at risk of domestic abuse. We saw an increase in opportunity for abuse to occur and a reduced opportunity for women to seek help or to remove themselves from those situations. Next slide, please. So as a result, we identified that a lot of our staff across the team, from our admin team to our medical nursing staff, actually had to feel a bit more confident at identifying the possibility of GBV on phone calls. So we allowed permission for our reception staff to be able to say just simple things like, could you turn off your speakerphone, it's echoing a bit, whether that was the case or not. And then almost validates the person on the other end of the phone to switch off their speakerphone so that no one else can listen in on that conversation. For most women, it may be that they're phoning now because it's only safe to do so. And we also encourage our reception staff to perhaps say that, you know, do you need to speak to someone immediately because it's only safe now, or are you fine for someone to phone you back later on? And for most people, a call back later on is fine, but it's really important to know what the number will call from and how the nurse or the doctor phoning them back will actually introduce themselves. And it might be that the woman herself might want us to use a name of one of their friends, just in case someone else picks up the phone. So that sort of sets the scene for women calling into our service. And it also assumes that women have phones. They have phones that can make outgoing calls. And what we've identified within the COVID pandemic is that huge inequality of individuals who just don't have digital technology. And perhaps one of our later speakers might look at that a little bit about how we improve access to services for those women who can't just phone. But going back to, you know, our staff who are then phoning patients back, we recommend to staff that they actually just take a little bit of time and breathing space before they make phone calls back. Make sure that they can have a quiet area, a lot of shared offices, but perhaps the use of headphones and not where there's lots of to and fro and going behind them. It means that they can really focus on the conversation. They can focus on what's being said and what isn't being said, and they can listen to their own gut instinct, which we do a lot in face-to-face, and it's a little bit more difficult with phone. We've put together a checklist for people to perhaps think about before they make that phone call. Have a plan in place. What you're going to do, how you're going to handle the situation if someone else answers the woman's phone. Suggest perhaps that we will switch off the speakerphone, always remember to do that, and then think about what's going on in the background. Are there children around? What ages might they be? Might they be able to listen in on a conversation, and a third party might get information from them at a later date? It might be during the consultation that you've spoken to that woman before and already have a safe word, or it might be the first time that you call that woman, and it might be appropriate to say to her, look, you know, if you are at risk or feel concerned during that consultation, you know, is there a safe word that you want to use that means that I can phone for help? It could be things, a word like Tuesday, it could be anything, but it's just something to consider. Next slide, please. The key thing is to stay alert for clues. We do that just unconsciously when we see people face to face, but just listen in. Do the words that she's using add up to the emotions that she's using? What tone of voice is she using? Is she dropping hints? Does she keep coming back to something? Almost like she's trying to get you to really listen and hear her. And then remember, although a lot of face-to-face appointments are significantly reduced with COVID, we can see people face-to-face after COVID assessment. And it may be that for that woman, in order to have a safe consultation, that we would arrange to see her face-to-face. It's important that you are able to really actively listen, and when you do that face-to-face, you can nod, you can make eye contact, and that's a bit more tricky with the phone. And we just sort of say things like repeat back what the woman said, say yes, go on. There's nothing worse than speaking down a telephone line just to silence, so it's important that you give these cues. And we know that if women are given a safe space and feel that they're being listened to, they might well disclose information. But when speaking to victims of domestic abuse, they often say, I wish someone had just asked if I was okay. And therefore, that's why we feel quite confident in saying to our staff, look, it's okay to do routine inquiry of abuse on the phone. You know, women won't be offended by asking questions, and women often just want to be asked, are you safe? Are you okay? Is there anyone that you want us to phone for you? Next slide. So it's just being conscious that we can ask these questions. Staff are often really wary of asking these things in case the woman says, yes, actually, I do need help, and then they don't know what to do. So we recommend it in our staff to have our local gender-based violence team, and that'll be different from board to board, or just have to hand the Scottish Domestic Abuse Helpline. The benefit of them is that they're available 24 hours a day, 7 days a week. And if women find it difficult to make phone calls in case they might be overheard, they've got an email system or web chat or text that can be especially useful as well. All of these resources are available in a video clip that's available on Tourist and also on the Vimeo.com app. And we have a poster and these slide sets as well that we're quite happy that can be shared across services as well. Although the slant of this is more around health professionals, we've had some feedback from other people on the ground saying women, GP practices, pharmacists and youth workers who also have found this sort of resource quite helpful. Later on in the presentations, I think they're going to speak about SRH access, and obviously I'm an SRH consultant and work within Sexual Health in Fife. And we have seen a lot of changes that we've undergone in terms of COVID, and our services changed overnight. And prior to this, we had engaged quite closely with women who were victims of domestic abuse, gender-based violence, substance dependency, or might have been homeless or in contact with the criminal justice system. And we effectively engaged them in a project looking at how they would prefer to be accessing sexual health services and what barriers they had to prevent them accessing services. And as a result of that feedback, we were actually able to develop something called the Acorn Fast Pass. Acorn stands for Access, Care, Respond to Need. There's a wee card here. And actually we were able to scale that up during the COVID pandemic across Fife, and it was almost a calling card that if someone showed or quoted the Acorn name when phoning or in any interactions with staff, it instantly alerted to staff that this was a vulnerable man or woman and someone who needed to be seen. So we would fast track them through to callbacks and face-to-face appointment. So I can pick up a wee bit more about the Acorn in the question and answers if that comes up, but that's the end of my presentation this afternoon.
So thank you very much. That was hugely interesting, and one of the things I actually wanted to ask you before we move on to Jenny's presentation was around the transferability. So you've obviously developed that within sexual health services. It's how we can move that across, and you obviously mentioned youth setting, criminal justice. So has there been any exploration about actually moving that work into those settings?
The GBV resource?
The GBV, yeah.
Yeah, it's actually gone out through Public Health Scotland, and Unison have picked it up as well. So, and we've certainly spread it through our own local networks, through Fife Council, etc. It's gone out more widely in the UK through the Faculty of Sexual and Reproductive Health and BASH. So, you know, certainly, we're hoping that perhaps in events like this, people in other boards might be able to share it, with their own partners as well. So.
No, it's very interesting. I think I'm sure there'll be a lot of people who have tuned in today that will find that something that, in terms of workforce development, we're all in a position now where we're having to look at our competence in relation to our telephone skills, because so many people are moving in that direction. So that's hugely helpful. I think what we'll do now is we'll move on to our next presentation. So if I could say goodbye to you just now and hello to Jenny. Is Jenny?
Hello, hiya.
Hi, Jenny. So I'm just going to leave you in the very capable hands of Jenny, who's going to discuss and tell us a bit about our work in Glasgow with women and homeless women who are HIV positive. So I will hand you over to Jenny just now. Thanks, Jenny.
Okay, thank you. Okay. Oh, right. Okay. Hiya. Thank you, Trish. Right. So I'm the women's outreach worker for Waverley Care. Prior to joining Waverley Care, I worked for over 10 years in housing support with care experienced young people, and I'm also a qualified registered art psychotherapist with experience of working therapeutically with children affected by parental substance misuse. So my role as women's outreach worker is to provide a gender-specific outreach service for women who inject drugs in Glasgow city centre. This was developed in response to the ongoing HIV outbreak in Glasgow amongst people who inject drugs. So we deliver gender-specific harm reduction interventions to women who inject drugs. And also I do one-to-one support with women who are at risk of contracting HIV or currently living with HIV. So what do we know? So from about 2015, 2015, HIV amongst female and male people who inject drugs was increasing at an alarming rate. It used to be about, prior to the outbreak, it used to be around about 10 new diagnoses a year of HIV, but this year alone, there's been about 10 new diagnoses within the first 3 months of this year, so that kind of gives you an idea of the rate. Okay, there's evidence and research that indicates that women who use drugs in Glasgow are disproportionately affected by this HIV outbreak. And across Scotland, women who inject drugs are 3 times more likely to be HIV positive than their male counterparts. And this remains the case even after accounting for other risk factors such as age and homelessness and cocaine use. Cocaine, we're increasingly seeing this is getting injected, and it requires to be injected much more frequently because the buzz is shorter lived. And the harsh reality of being on the streets, there's a high likelihood that you'll use drugs to dissociate from this. Okay, international evidence shows that gender-based violence significantly increases the risk of HIV amongst women who use drugs, and I'll touch on this a wee again in a wee bit further on. So specific challenges to homeless women during coronavirus. All the usual issues are still there, but during COVID-19 and lockdown, it's made these issues much more amplified. So I've kind of broken this into headings to help me speak about it. But one of the things is finance. So prior to lockdown, women were begging to make their money, but now suddenly they're faced with the streets are totally dead and they're completely empty. So you need to consider that income lost from begging, there's income lost from buying food. A lot of money could be saved by strangers donating food to people on the street. We've all done it. We've all bought folk a coffee, sandwiches, etc. And also to think about income lost from shoplifting as a potential income. All the shops are shut, so Glasgow city centre is like a ghost town. So this begs the question, what desperate measures are women going to end up in order to fund their addiction? And let's be clear, addiction's not a choice. So this kind of leads us on to safety and the empty streets during lockdown. Women on these empty streets are very visible. We need to consider the safety that there was in crowded streets. More people around to witness anything untoward happening. In empty streets, these lockdown streets, then predatory males are hovering around, looking to exploit that vulnerability. So the women have lost these safer avenues of income, and so are at higher risk of gender-based violence. For example, engaging in or being coerced into transactional sex as payment for drugs, and that might be to fund their own habits, but also that those who are exploiting them. Women who are involved in prostitution have told us that men will offer more money for vaginal and anal sex without a condom, and there's a higher risk of contracting HIV this way. And a lot of women are in codependent relationships, and this is a bit of a double-edged sword, and might be a protective factor, yet exploitative. And again, we're looking at transactional sex. Partners might pimp out their partners for their own gain. Okay, so if you look at drug use in HIV, what I've heard from women that we work with is that many of them, they struggle to inject themselves. So this opens up the question, who is injecting them? Is the needle clean? If people are injecting on the streets, that often means poor injecting practice. Shared equipment and unsanitary conditions, and this increases the risk of contracting HIV and Hep C, but as well as the risk of damaging and missing veins, which can lead to abscesses and infections. Okay, so if you look at accommodation during COVID, all the homeless people, they were scooped up and accommodated into hostels and hotels. So a lot of benefits to this. Chaotic users, drug users are now accommodated, so we now know where they are. This has created really valuable opportunities for outreach pharmacists, the outreach nurses, and the bloodborne virus and sexual health teams to link in and support them to access the healthcare they need, including their ORTs, so methadone prescription, their ARVs, which is their HIV medication, and PrEP, which is a drug when taken regularly can help block your HIV infecting the body. So, but We also need to look at how quickly accommodating the homeless was very much about COVID-19, and it wasn't. It's not about individual need, so it's far from ideal. So you're kind of looking at a situation where women, well, on one hand, they're off the streets and they're safe, and they've got their own room, etc. But perhaps they're being accommodated with people they've been trying to avoid. Drug dealing within shared accommodation can be rife, and it is rife. We're hearing for that, and the temptation to use drugs increases due to availability. We've had women reporting increased drug use in a bid to relieve boredom, anxiety, block out past trauma, and if they're injecting unsafely, this is increasing the risk of contracting HIV, and again, a higher risk of transactional sex. So if you think about their lower income but increased drug use, how are they paying for that? How to pay for that when funding avenues have been cut off? So also there's a report, the drugs haven't gone away, but there's a report that has been focusing that the quality of them has depleted, so perhaps using more to get the same hit. So lower tolerance levels, which increases the risk of overdose. There are more deaths through overdose and more near fatal overdoses as well. There have been deaths in the accommodation, and people are more hidden away in their rooms. Again, if they were on the street, as horrendous as that is, there's more people passing, there's more eyes, there's more people who can check, are they okay? We also need to look at how hotel staff who are running these hotels, they're not trained in social care. They're in a situation now where people with massively complex needs are living in this pressure cooker environment, and folks' mental health is suffering horrendously. If you look at the recent tragic events at the Park Inn Hotel, that brings that right home. We also have, in terms of drug use, this even prior to lockdown, but we were seeing a lot of more people were buzzing gas. So cheap, and this, I mean, this creates huge fire safety issues as well as a health issue. So we were hearing of women who have their placements are breaking down quite quickly, and some, in one particular case, a lot to do with the gas use. And let's see, also during COVID-19, the reductions in services. So loads of services suspended or reduced, including our own, and delays to folk getting treatments for women, like accessing long-term contraception is an issue. If you look at medication as well, people were getting their weekly prescriptions instead of daily dose, so they could get the methadone to take away and manage this themselves. For some women who were more stable, this was a positive for them. It meant they didn't have to travel long distances, it saved them money, and it gave them an opportunity to prove they could be trusted. The flip side of this was, though, there's an increased risk of overdose, and also there's some people who are too chaotic to manage that. Also, if they're too chaotic to remember to take their ARVs, their HIV medication, then it's going to take longer to get to for them to get to that undetectable, untransmittable status. They're not going to manage that well. Let's see, stigma is still there. Also, with reduced services and social distancing, people are queuing outside pharmacies. There was a real fear of being seen taking their ARV tablets within the chemist, and so that their status might be given away, and that was a very real fear for some women. Also open to exploitation. If you're seeing queuing and it's known you're getting your weekly pickup, somebody might want to take that off you. Everybody hates queuing, and if you're rattling and you're in a queue, that's a very real thing. So, I think I'm whizzing through this. It's kind of disconcerting as well because I can't see anybody now. I don't know what's happened to my screen.
Jenny, I've come back on now, so but I think we're just looking to wind up, but you've covered a huge amount of ground there.
I know. I've only got a tiny bit left to go, so I can just always do that. I think travel, that was another big thing. It's very hard for folk who are catered abuse to make appointments. So one of the big things I think was during COVID, we're all being discouraged from using public transport. So if women have got respiratory issues through years of smoking heroin, you know, they're in a high risk category. So so for them, that the fear of catching COVID by getting on public transport is a very real thing also.
Yeah.
So I'll wind it up there, and there'll be loads of missed, so you can ask me questions at the end.
Well, I mean, I've got a whole range of questions I'd love to ask you right now, but I'm not allowed to, so I can't. But you know, I think what you've done quite clearly there, I think that was very, very helpful. You've certainly, for anyone who didn't understand what the reality is for individuals, women or men, in fact, because some of these issues obviously relate to all individuals in Glasgow who have experienced sort of been taken off the street and put into hotel accommodation, and some of the issues generally around the outbreak as well. So you've clearly painted a picture, I think, and you've really teased out some really key issues and really what some of the risks are, and some of the new risks that are there as a result of COVID. So I would just like to thank you very much for that. And we'll get you back in after the last presentation. So I'm going to invite Katherine on screen. Katherine, hello, are you there?
Hello, yep.
Hello. Oh, super. So I'm going to pass over to you. So folks, Katherine's going to be discussing the access issues with regards to women and sexual health, sexual and reproductive health services. So I'm going to hand over to you, and I'll see you in about 10 minutes. Cheers.
Thanks very much, Trish. Thank you. Hi there. Thank you so much for having me along. This is great to be part of this panel. It's fantastic. So I'm Katherine. I'm one of the nurses working at the Chalmers Sexual Health Centre. My background was I worked in London initially, and then in Uganda for a little while before I came to Scotland, all kind of running and managing sexual and reproductive health and HIV services. When I first came to Scotland, I was based in the infectious disease unit, mainly doing HIV, and I've been over at Chalmers for the last 5 or 6 years, and my lead role there is in access and supporting the WISHES service, which is our inclusive sexual health service for women with a range of needs. So I'll just get you to move on to the next slide if you can. Thank you. So what are we talking about? So for those of you who spend a little bit less time than I do in sexual health services, I just thought it might be helpful just to kind of discuss the kind of things that we would be looking at addressing and supporting women with when we see them. Obviously, some of this work is done in other places as well. GP practices do a lot of sexual health support and work. Community pharmacies, you guys might be doing some of these yourselves already, but it's just to kind of give you an idea of the kind of things that we'd be trying to support and look after women to get access to. I think the distinctions that I've made there between acute and routine, it's really just about how urgently and how quickly we'd like to see something. Often with women, especially with a range of needs, we may well start seeing someone specifically just thinking that they want an asymptomatic checkup, but end up giving emergency contraception, actual long-acting contraception. They might get a smear test. So often kind of one thing leads to another, and we love to be able to be opportunistic when we see people. So that's kind of, it's often more than just 1 or 2 things that we do in any given session. Next slide, please. So the services that we have delivered up to now, so the way we've looked after women involved in drugs in the past, we've tried to provide kind of, I guess, a 3-pronged approach to support access, because we're aware what kind of challenges, and some of them have already been mentioned in the previous talks, there are all the time to getting into sexual health. So we aim to have a drop-in service primarily to make sure that we can be flexible. WISHES runs a drop-in twice a week, and we have a clinic out in Wester Hales. Priority access is our sort of fast-track service for partner organisations who work with more vulnerable groups to make sure that their clients can get fast-tracked through. It sounds a little bit similar to the Acorn project over in Fife, and it just aims to get people through without long waits and to make sure that they can get the services that they need quickly. In terms of outreach, we've got a nurse dedicated to that, Sophie, who spends time out in the community every week from a WISHES point of view, but we're also aware that we as specialist services can't be everywhere, and one of the things that we focused on in the past couple of years is training and supporting nurses working in different areas, so inclusion, health, substance misuse, harm reduction, to try and give you guys the skills to do some of the work there yourself. And actually that's been brilliant. The nurses that we've trained up are doing loads of great work, and it's, you know, a lot of the skills, there's a lot of cross cover with your skills and ours, so that's been really effective. Finally, the education and advocacy is the final thing we try and work on. So one of our doctors, Nikki, does some work. She does quite regular training with third sector and non-NHS partners, which maybe some of you have been involved in the past. Alison, our consultant, does a lot of advocacy at government level, and so we kind of try to cover things from all of those angles normally. So next slide, please. So what have things looked like for us during COVID? Well, we've already heard a lot about the huge amounts of challenges that all services have been struggling with, and we're obviously no different in sexual health. So as Sue mentioned at the beginning and really articulately described some of the challenges, we've moved a lot across to the phone. So the way that we've done that in Chalmers and in Lothian is that people can book online, or they can arrange a phone back via our phone line, and then one of our clinical team rings back at a specific time and does as much as possible in the consultation over the phone. We have got capacity to still see people if they really need to be seen in the building, but we're limited in terms of footfall quite significantly. We need to give people very specific times to come in. They're supposed to be in just for one sort of specific intervention rather than lengthy chats. So it's really changed the way that we work with people when we're seeing them face to face, as I'm sure it has in a lot of areas. We've lost access to some of our local clinics because obviously buildings are being used for other things, and we're hoping to start getting them back over the next few weeks and months, but that's changed and reduced our presence in areas outside of central Edinburgh, quite significantly recently. Obviously from a government point of view, from a logistics point of view, from every point of view, we've been restricted in what we can do, especially in terms of the routine work that I mentioned at the beginning. And as with everywhere, our staffing has been reduced. People have been shielding or moved away to different services, and that's impacted on partner organisations as well. So that's kind of an ongoing challenge for us all, I guess. But I guess the other side of that is that we have been prioritising trying to support women with complex needs all the way through, and it's got kind of easier as things have opened up a little bit more. But that is important to note. We have in Lothian been working in a similar model to some of the stuff that Jenny was talking about in Glasgow, to try and get out and do direct support and assertive outreach in hostels. We've worked with harm reduction, the access practice, and the bloodborne virus team to kind of try and liaise about what's needed where, and get out and do kind of specific work when that's needed. And we've been out and seen women fitted contraception, done screening, etc. And the guys are also doing point of care tests for HIV and syphilis, as well as other screening. So that's been great, and hopefully that will continue moving forward. In terms of termination of pregnancy, so abortion services, there's been quite significant changes over the COVID pandemic. The legislation has meant that now we're able to do full phone consultations for women who are suitable for an early medical abortion at home, and actually they don't need to come in to take the first part of their treatment, which they used to have to do, and they're able to just get everything either picked up from the clinic or sent out to them. So that's been a really positive change to allow women to be able to, if it's the right thing for them, be completely at home throughout that process. In terms of testing, we've been sending out quite a lot of testing kits for chlamydia and gonorrhea in the post, and we're also we're just gradually trying to fix up the logistics of getting self-sampling for HIV and syphilis and other bloodborne viruses, so that people can actually send samples straight through to our lab and get a full set of test results from that. So that's kind of in progress at the moment, and hopefully will be being rolled out soon. So that's been great. Next slide, please. So in terms of how the sort of more general changes to sexual and reproductive health services impact the group that we're talking about, women who use drugs. So I guess we would like to run drop-ins. We like drop-ins. We find them flexible. We feel like it allows women to come and use our services as and when they choose them and feel ready, and we're able to spend the time that we need with them. We're obviously keen to get back to doing that as much as we can, as soon as we can, and that is in progress. We like to be able to see women in person because, as Sue's already described, it allows us to make sure that we're keeping them safe. We know that women with a history of drug use, as has already been mentioned, often got a significant history of trauma, and we're able to sort of take our time with that normally, and we're trying to feel our way in how we fit into our kind of current mode of practice. But I guess the only thing I would say is I think I was really nervous about the phone consultations, and it is more phone than online that we've been doing. And and feeling like that really was a block. But as Sue said, there's actually a lot that you can do on the phone. We're able to, and for some women, it's suitable for them, and it's pleasant not to have to trek into a clinic and talk in person. You can discuss embarrassing things without having to look at someone. So I think although we feel nervous about what we've lost, we're also, it's exciting what we've gained, and that we're able to maybe deliver care in a different way. And I'd really hope that we allow that access to happen across the board for women, regardless of where they're coming from. So we'll talk a bit more about that in a second. Safeguarding, Sue's talked about a lot. We're really aware of that, and as Jenny mentioned as well, you know, certainly keeping women safe, especially if they've got significant financial issues as a result of the pandemic, and maybe have ended up needing to sell sex to get accommodation or financial help. We would be looking to support them as much as we possibly could. And I think the main thing that I'd say is that we, like Sue, have got a really low threshold. We would bring people in if we felt there was anything that needed further discussion. So we do, even if we can't do drop-ins, we have a low threshold to bring people through. So in terms of outreach, we're going to continue to build on our networks and hopefully keep that work going. Access to technology carries on being an issue, as Sue mentioned, and I guess that's where you guys come in. I think over the years, many of you have brought clients over to see us in sexual health services, and I guess that maybe now I'd sort of flag up that your role might be more to support people to use phones and technology if they don't have access to that, so that initial phone call might be possible until we're able to open up drop-in services wherever possible. So that might be great, and you may end up not needing to come all the way up to services. We might be able to support patients in their own areas to get what they need. And we're all running dynamic risk assessments all the time from a COVID point of view, but also for all other risks that we're generally having to deal with. And we know that a lot of those have increased with the pandemic. So in terms of the final things, I guess it's just things like this are really helpful for me. I know I've learnt loads from working with the harm reduction and substance misuse teams, all of the innovative work that's been going on during the pandemic. We're trying to learn as well from that, and it's great to be sharing the approaches with you. I finally would just say that I think we've got a real need to continue to advocate for the women that we're working with, because services have been reduced and access to long-acting contraception is reduced, and we just need to keep fighting to make sure that this stays up on the agenda and we don't lose ground that we gained over the previous few years in the result of the pandemic. And so I guess my final message is you guys are really important. We're still here, we're still offering services. We really, really want to see the women that you're working with. We might not be as easy to get into as we previously were, but maybe we are in different ways. So please find out what's going on in your area and continue to contact the teams, and hopefully we'll be able to provide the help that your clients need. Thank you very much. That's me.
Thank you so much, Katherine. That was hugely helpful, and I think that's really, really important to stress that, similar to what you're doing, that's happening in other areas in Scotland in terms of other sexual health services, in terms of that adaptation and how people are moving and using technology, but they're still there. There are still clinics happening, and it's important that folk are aware of that. And that they link in with their local sexual health service. I know that we're going to be moving on to the Q&A in a second, but first of all, I just want to say as well, thank you, because folk won't realise that you're actually giving us some of your annual leave to take part today, and that just shows your commitment. Well, that just shows your commitment, which is tremendous. But I wanted to just double check something, and again for my learning, but perhaps for other people who are logged in today. The Near Me consultation, that's purely telephone, or is it?
So sorry, yeah. The Near Me is the NHS. It's essentially video phone consultations. Right. So it's been useful. I think generally we found people haven't chosen it, but obviously for people who've got hearing difficulties, then obviously that's the first go-to. But also some people have opted for it or chosen it, and in different areas of our service, it's being used more than others. It's being used quite a bit in gender. I think some other services are using it more, but generally people have often chosen to use the phone, and I think part of that's about it feeling a bit more anonymous. As I said, it can maybe be a bit easier and quicker just to jump into that, but it's absolutely there, and you know, it may be that we end up doing that more and more as time goes forward.
I think that's the point. Yeah, absolutely. So we'll hold it there, because hopefully everyone who's online, there'll be a number of questions submitted. So I'm going to invite Sue and Jenny back, and also invite Leslie into the party. Leslie, are you there?
I'm coming.
Feels a bit like Mortling Orson, Min Orson. So good stuff. So Leslie, you've been obviously in charge of the questions that have been coming through and the chat. So can you give us an idea of some of the questions that have come through, and then I'll be able to see who's perhaps best placed to answer that. That's great.
Absolutely. Got a number of questions here. If we don't get through them, we'll get all the answers out to everyone that's watching. So keep the questions coming in if you do have them. First question we've got though is about Sue and the resources, and there was a question there about, did women with experience of gender-based violence, were they involved in the design of the service and the resources that you were mentioning?
In terms of the resources of the video clips, etc., we actually linked in with Scottish Women's Aid in sort of development of that, and actually Hazel White from Open Change did the lovely illustrations. In terms of the Acorn card and the Fast Pass, we worked through SACRO in Fife and the Wings project for women, and a team of Sexual Health went out to all of the Wings sites across Fife, and we had a really informal, relaxed soup and sandwiches, tea and biscuits, chat with the women. We shared information, they got to know us, and our nurses from our BBV team and our Sexual Health team, Health Improvement, and myself all went out, and we actually got a lot of really brilliant stories from women, experiences, not only just from experiences of accessing sexual health services, but also primary care. And we, pulled that into themes which are around sort of knowledge that women's perceptions was you just go to sexual health when things go wrong for EC or for abortion care, and they didn't realise all the preventative stuff that we did, from vaccinations and so on. Professionalism around them feeling judged, whether they were or not, their perceptions were, and feeling unimportant, so that came out a lot. And the third thing was just about availability and responsiveness of services, so feeling like they needed to be seen now, which is why, as Katherine said, drop-in is really good for this group. They just want to go there and then, but they can't wait in queues, etc., which I think Jenny picked up. And the barrier a lot being reception staff and flippant, having to wait, just attitudes and things. So allowed us to work with these women again in the name of coming up with the Acorn Fast Pass and actually how it would work. So if you showed it, it means you will be seen, you won't have to wait, etc. So it's almost it's a kind of two-way thing. It's saying, if you show that, this is what we will provide for you. And it was only really just launched at the end of February, and we didn't see many women yet through with the Acorn card. But the evaluation so far on the women who used it said that actually without the card, they wouldn't have had the courage to pitch up at a service. Yeah. So certainly that's why we felt we've actually shared it out wider in Fife through our family nurse partnerships, through criminal justice and so on. So done a wee bit of work also with women whose partners were released early from prison, because that's often another group in terms of people at risk of sexual ill health, that there was a particular issue around COVID. So yeah. Hope that answers some of the questions.
Yeah, that's very helpful, Sue. I'm going to move on because I'm conscious that time is moving forward. And Leslie, any other questions then?
Yeah, the next question that we've got here is about how is access to treatment, whether it was day-to-day treatment for HIV medication, it could be for OST, it could be for any treatments for sexual health, but how has the day-to-day access to treatment changed for women during COVID and lockdown?
Jenny, I don't know, do you want to take that one? In terms of your experience, obviously that's very specific to women that you're working with in Glasgow, I would say, rather than sort of the generic population in terms of women who are living with HIV. But I think nonetheless that would be interesting to hear how that particular part of your work's actually been affected.
Yeah, I think like mentioned about travel and transport and getting buses and things, during COVID we're being discouraged from using public transport. So for a lot of women, people who have an HIV diagnosis, the Scottish Government can provide a travel pass, so they can use the transport for free, which is better, or reduced fares. But the delays in these travel passes coming. They, even before COVID, then we'd had people were waiting for up to 9 weeks, if not more, to get these bus passes. So, but also people are using drugs. It's memory problems. There's just lower priorities. HIV is probably maybe quite low on the list of priorities, given all the difficult things that are going on in their life. So, and then getting to clinics. One of the things in some of the homeless clinics was prior to COVID, they'd noted that actually for women coming into the clinic, there was loads of predatory males just waiting, just in the waiting rooms as well, ready to exploit that vulnerability. So they created then women's only clinics for that. But without them being able to get in, and if they're having to wait outside now, if they are getting there, there's been quite a lot of challenge.
I suppose the issue in terms of people's understanding about what we're trying to achieve in relation to HIV prevention is that we need to find people who have been at risk. We need to test them. We need to get them engaged in treatment. And then once folk are engaged in treatment, it's about keeping them on treatment and the adherence element, which obviously, given the disruption that we're all facing, that's where the big risks come in terms of actually ensuring that particularly vulnerable women are able to adhere, able to get out. I mean, bottom line is if all they've got is a bus pass and they're trying to get to clinic to get medication, then and we're being discouraged from using public services as well, public transport. There's a whole range of issues there. Does someone else want to come in on that one?
Yeah, I just wanted to say, Trish, certainly many services are actually delivering HIV medications to their vulnerable groups or those that might be shielding, and I'm sure that's probably the same across all the boards as well. And in terms of other STI treatment, we're still having to see individuals for IM treatment for gonorrhea and syphilis, but we work really closely with community pharmacies to provide doxycycline often at local level in pharmacy. So there's been really great examples of joint working across all sectors.
I absolutely endorse that, certainly based on our experience in Lanarkshire and our clinical services and what they've been doing. And it's the same for addiction services as well, in terms of how they've been supporting individuals and making sure that medication's getting out. So people have been, you can say it's creative, but certainly pragmatic, I think, in terms of their response, which has really been good to see. I'm going to move on there. And Leslie, any more questions?
Yeah, got one that's just come in that says, due to being able to engage with more homeless women as a result of COVID, do you think this is one of the reasons for increases in HIV diagnoses? So I think, I'll say that one again. So, due to being able to engage with more homeless women, so we know where they are. I think you were discussing about they are now all in large hotels or hostels, so they're in one place. Are we finding that it's easier to diagnose, and therefore we're seeing more diagnoses coming through for people?
I think at this stage, a lot of I don't know, that a lot of testing has been reduced. So we're really what we're looking for now is we really want to get loads of testing done, because now since COVID's hit, there's a huge reduction in that. So and people are still using drugs, so it's actually going to be quite scary, I think, to see what the stats will be, what the increase will be. So right now we don't know.
I think I would endorse that, and certainly in terms of that's reflected across Scotland. So the drop in BBV testing generally is something that we're all really concerned about, and actually trying to then get that started back up, and really what will happen in the, and what's happened in the meantime. Let's be honest about it. We know that there's been an increase in alcohol use, and the drug use is still happening, and it's changing, and it's increasing in some ways. So what that actually means for us, that sort of perfect storm, when we actually go back to doing what we really have wanted to do all this time, I think you're right, Jenny. I think we are going to uncover probably more diagnosis, particularly in relation to HIV. Does anyone else want to come in on that one, or will we move on to another question?
Yeah, I just wanted to say, in terms of what we found is actually two groups of women and men who've come forward during COVID who hadn't before, and that's people who are known Hep C and always declined treatment previously have started to come forward, and women who've never had smears before, which is a particular issue in this group of women, have started to ask about smears. So I don't know if there's been something just about the whole COVID pandemic and kind of reevaluating your life, your family, everything. But certainly we're locally noticing people coming forward who hadn't before. And I think it would be nice when the smear programme gets, up and running again, that actually we can facilitate access for those women who have never had smears but might have the courage to come forward now. And I see that increasing.
Yeah. Yeah, thanks for that, Sue. Leslie, I'm conscious of time, and
next question.
I know there'll be a number of questions there.
So we've got a question here about what advice would you give to other NHS teams that have never maybe done outreach before in terms of moving to an outreach model? Is there any lessons to learn there?
Jenny, I feel as though we're...
Is it Katherine maybe as well?
Yeah, of course, Katherine, you've been involved in doing outreach as well.
So
we'll give Jenny a rest, I think, at the moment, and we'll hand over to you.
So I guess, we've been learning from other people who do it more, I would say, is our kind of the first thing we've been doing. So we've been spending time having discussions with teams that have had outreach as more part of their core work going, all along, and trying to find the bits of their experiences that are relevant and helpful for us. And we've done some joint working. So we've gone out in teams with for example, the harm reduction workers to hostels, just to try and get a sense of how they manage working in different environments. And obviously in terms of governance and safety, we've used SOPs and setups that we've got for different teams, and we've been kind of adjusting them and flexing them to fit the current situation, and kind of learning a bit by doing as well, seeing what works. I mean, we as we said, at the kind of outreach that we've been doing, we thought it would be a model where we would go out a lot with the harm reduction teams, but actually we kind of found that we were doing slightly different work, and that actually it was more about identifying a need. And what we've ended up doing has been going out more once we know specifically that there's someone that needs to see us. We didn't just kind of show up in the hostel cafe and start chatting on about sexual health with everybody. It was more about once someone had mentioned that it was something that they were interested in talking, or there was women there that had said that they were concerned or they wanted to have that chat, kind of being a bit more targeted. So I guess that we've kind of been trying to evolve what we've been doing as we've gone along. And just kind of constant learning and a lot of sharing of knowledge, I guess, is what I would say.
Yeah, and I think the sharing of knowledge is key, certainly across, in terms of where we're all at with regards to COVID and doing things differently. I think for outreach, certainly, I can only speak from what's been happening in Lanarkshire, and we have been doing more assertive outreach, particularly our third sector services, and certainly our NHS harm reduction team have been doing well established and been doing outreach for well over probably even 2 decades now, frankly. So they are one part of the statutory service that has got huge experience in it, and we've all been very much learning from the harm reduction team in terms of what they're doing. But I think that in terms of what outreach means for different, probably means different things to different people, and there are obviously differences to doing harm reduction in a city environment. So both yourself and Jenny obviously are working in Edinburgh and Glasgow, and how that then transfers into a sort of more township rural setting is slightly different. But ultimately it's something that it's another strand, another way of working that we all need to be developing. I would certainly agree on that point. I'm looking at the time, and my watch it's 54, but I think we've maybe got time for maybe another question, Leslie. We push one through, maybe one or two.
Have you got good examples of getting women access to digital technology locally that you've been using? So that could be phones to help people get in phone appointments, video appointments, etc., and/or credit as well.
I'll leave that as a free one. All I can say myself on that is that I'm aware addiction services have certainly been involved in providing phones and technology. From sexual health services, I'll leave that open to probably Sue or Katherine, I don't know.
I suppose we haven't done it directly through sexual health services, but we're working quite closely through what we're calling an inclusion team with harm reduction workers and homeless team. And one of our harm reduction officers, Louise Boma, is actually sort of setting up a food bank for phones almost, so that we're trying to gather up phones that we can issue them to people who require that. But it's something that we are feeding back at senior level and actually through to government in terms of what changes would we like to see ongoing from COVID. And I think phone, digital technology, access to internet is as important as a roof over your head and food, to be honest. And I think it's really been highlighted in that. So we're doing a bit of work locally around the phones, but I'm sure there's other good practices elsewhere.
Yeah. Katherine, do you want to come in? Is there anything you'd want to add to that?
No, that sounds great. I'm really interested in that. I think we could probably benefit from some of that in Edinburgh.
Yeah. Have we got time for one more?
One final question. If there was to be another lockdown again, what would you want people to be having in place to safeguard women?
Leave
the hard one till the end.
I don't know who wants to jump in on that one and answer that one.
I think we're actually in a pretty good place at the moment. The digital stuff, I think if we can get more access to phones, etc., because that will be vital. But I think, the transformation that certainly our service, and I'm sure many have gone through in the last 3 months, is probably equivalent to about 3, 4, 5, 6 years of usual time. So I think we're in a place where I think we could never have imagined to be, and it's just to continue, going down that line. And I think key also is to ask people what they want. We're doing a bit of work around sort of what matters to me type work with those who are homeless, etc., to actually see what is it that they want before we then develop services any further. So I think we're in not too bad a place for preparing for any potential further lockdowns.
We're all nodding in agreement. I'm going to hand over to Katherine for the last word on this one.
But no, I think data is what I would like to go in. As you say, I think that we need to be really evaluating, because I think, as I sort of was trying to say, I think, like Sue said, all of the services have changed and developed so much, and some of it was by necessity. All of it was by necessity, but some of it maybe is stuff that we're really looking forward to moving on from, but other bits are stuff that we want to kind of keep a hold of and can inform our practice and improve our practice, make it more flexible going forward. So I think it's kind of finding out what we want to keep, and that comes in terms of how the feedback from clients and patients, but it's also a bit about how it works for staff and making sure staff have been really thrown into managing situations that they never thought they would, and Sue explained that really nicely early on, and I think it's just about supporting them and finding ways to make sure that that's sort of sustainable going forward.
I think absolutely, and I think that just taking Sue's point, we've been to use the term fast-tracked again, but we have been completely fast-tracked into. There's been less dithering. I think is probably the best word I can think of. In terms of how we've moved services and taken risks, and that we would consider to be risks, and in actual fact found out that actually having taken those supposed risks, things have been okay. And so there's a huge amount of learning for us, I think, over the next weeks, months, years, possibly, in terms of how we move forward and make things better for the people that we serve. I'm just looking, it's 59 on my watch, so I am looking to wrap up now, if that's okay with everyone. And so really we've come to the end of today's webinar. And it is important that we are able to use today's shared learning experience to improve our understanding, our practice, and ultimately our service provision. So please share what you've learned today with others and colleagues in your service. And really with that in mind, a reminder that today's session has been recorded and will be published on the SDF YouTube channel probably as soon as possible, so it will need to be edited, etc. So another opportunity for you and for others to watch today's presentation and discussions. Leslie has already suggested that she'll be working on any questions that have not been answered today, and a report will be published on that. You can also view all of the previous webinars. I think there's been 6 or 7, maybe even more, on the YouTube channel. And you'll also be sent an evaluation, and we'd be very grateful if you could complete that for us for today. The next webinar is going to be held as usual on the Friday, so next Friday the 24th of July at the same time, 1 p.m. and its heading is Hitting Scotland's Hepatitis C Elimination Target with Prevention and Harm Reduction. And it takes place roundabout close to World Hepatitis Day, which takes place on the 28th of July. So the webinar will highlight broader thinking about how prevention and harm reduction contributes to the Scottish Government's 2024 elimination target, and importantly to also ensure that there are no future outbreaks once the goal is reached. A link to register for this webinar will be included in the evaluation email you'll receive, so it would be great to have you join us again. And finally, can I just thank you for your attendance today, for your questions as well, and a special thanks today to our speakers, to Sue, Jenny and Katherine, and to Leslie, Andy and Sophie Milton from SDF for their support in front of the camera and behind the scenes. So suffice to say, that's us for today. Have a good rest of the day and a good weekend, and thanks again for being here today. Goodbye.
Okay. Bye. Thank you.